Good evening, everyone. Thanks for joining today for this webinar. This is the first webinar organized by the Indian Society of Oncology in its series, and this is being done by our vibrant executive committee members led by Dr. Sabita, Dr. Sumant, and Dr. Samir. We will be having these virtual tumor board webinars every fourth Wednesday of every month, and this we will try to involve specialties, all the specialties, so that it becomes really a multidisciplinary tumor board and it will benefit all the subspecialties. So I wish you all the best for this educational series. Over to you, Dr. Sabita.
Thank you, sir. Thank you for your good wishes. So good evening, everyone, and a very warm welcome to the first virtual tumor board, which is being organized by the Indian Society of Oncology. We have a varied and diverse panel from different parts of the country, different types of institutions, different types of practices. And we are starting this month with breast cancer because not only is October the Breast Cancer Awareness Month, but also because it is one of the most common cancers where evidence is rapidly changing. So how do we apply this in the clinic in day-to-day life is what our experts are going to take us through. As most of our patients present to us with locally advanced breast cancer, this is the topic that we have chosen for our first webinar. And to take us through this webinar, I will now invite Dr. Richa Chauhan, a prominent senior radiation oncologist and the academic in charge of Mahavir Cancer Sansthan from Patna. Over to you, madam.
Thank you, sir, and thank you, Dr. Sabita. Can we have the slides, please, Neelam? Okay. So for the panel discussion on locally advanced breast cancer, we have an esteemed group of panelists. Let me introduce my panelists. I cannot move the slides, Neeraj. Just move it for me.
Now you can do it.
Okay, thank you. So on our panel, we have Dr. Nitesh Rohtagi, medical oncologist from Gurgaon, Dr. Neeta Nair, a breast surgeon, Dr. Priya Iyer, radiation oncologist, Dr. Manda Mahajan, oncoradiologist, Dr. Tanay, oncosurgeon, Dr. Neha Sethi, an oncopathologist, and Dr. Mansi Vesala, genetic counselor. I welcome all of you in this panel. I hope everyone is here.
Sir, only Dr. Nitesh is about to join.
Okay.
Others are there.
Okay. So we all know breast cancer is so common. It is the second most common cancer worldwide and the most common cancer in our country. And as Dr. Sabita said, it is the locally advanced stage that most of our patients, they do present to us. So coming straight to the panel, I have two questions for my panelists. How do you define a locally advanced breast cancer? And what percentage of patients in a clinical practice present with LABC? I think anyone can take this, the surgeon. Usually the patient with a lump comes to a surgeon. Dr. Neeta?
I'll start and then Tanay can take over. So I think, fortunately or unfortunately, I've seen both practices. Was with Tata till 2 years ago and now at Apollo. In a private setting, I think for me, my percentage of patients with clinically advanced, locally advanced cancers has become much lower. So for us, a locally advanced tumor would be something that is T3 more than 5 centimeters or a T4 disease. And of course, any T size that is N2 or N3. So for that kind of tumor, fortunately now one doesn't see it as the same proportions. Originally in Tata, we used to see them as 40% used to come as locally advanced. I'm going to say in my current practice, it's about 20 to 30, little under 20%. Tanay, any difference?
Yeah, so I would go with the number you stated in Tata. So we are still in Ahmedabad and all across Gujarat and southern parts of Rajasthan, all the patients are coming to us. But till now, we have almost 35 to 40% of patients presenting with either more than T3 or, T3 or higher stage or nodal positivity. So yes, around 40% is still the patients are presenting to us with LABCs.
Dr. Priya, what's your take? How often do you see an LABC patient at your center?
So at our center, we we see a very large volume of locally advanced breast cancers. And I would say any cancer of the breast from stage 3 onwards comes as locally advanced. So it can be operable or inoperable. And we see around 45 to 50% cases of locally advanced breast cancers in our practice.
Rightly. So these are some data from National Cancer Registry Program. Would they say that 57% of our patients, they do come in loco-regional? And okay, at our center, it's even higher. I would say close to 70% of our patients. So moving on. So this is the case we're going to discuss today. She is a 55-year-old obese lady who presented with complaints of lump in right breast for last 2 to 3 months, and that has increased in size and become painful for last 10 days. And that is why she reported to our center. She had menopause 5 years back, had 4 live births. All the children were breastfed for at least 9 to 10 months. Only significant history is a history of hypertension, for which she is on medication for the last 4 years, and there is no significant family history. Okay. So how to approach or manage this case? I think any of our clinician can take this case.
Hi, ma'am. I guess on examination, you said there was, say, a fair amount of lymphadenopathy?
Yeah. So this was the case.
Okay, so I mean, this patient is obviously LABC, so you need to work it up with a systemic scan of some sort. You clearly need a biopsy. I don't know if FNAC will help. You clearly need a core biopsy to know what her PRP or PPI index is. And I think that will open up your the next option. You could end up doing a mammogram, ultrasound, MRI, everything, but that depends whether it's metastatic or not. If it's not metastatic, you will need a lot of local imaging. Or if you want to be very thorough, you can do local imaging. But if it's metastatic, depending on the biology, I don't know if that's required or not.
So this lump is definitely suspicious and we want to do imaging in a patient. So what are the methods, what are the techniques, and what do you suggest?
This will be ultrasound guided core biopsy. The question of role of local imaging comes in when you actually debating what are you dealing with. Now, we don't know what we are dealing with right now. This looks like LABC. It's somewhat short history, inflammatory tumor. So my feeling was get a biopsy, get a systemic scan of some sorts, whichever.
So I think, what do you suggest? When to go for an ultrasonography, when for a mammo, and when for an MRI?
Yeah, so I'm Dr. Vandana. So good evening, everybody. Now, for this patient, after you have clinically examined, you have to decide, the first modality of investigation is a sonogram. So you will do an ultrasound of the breast, and anyway, she's 55 years of age is what I gathered. So 55, you will need an ultrasound plus a mammogram combined modality. Normally, in our practice, we do mammogram plus ultrasound as combined. So no, mammogram is done irrespective of this thing. Now, the second thing is, since 55 and not a younger age group, so mammogram will be indicated. So once you do a mammogram and the sonogram, so you will be able to make out whether it is a single lesion, multifocal lesion. At least you will have a basic idea about the number of the lesions in that and the local involvement, the skin involvement. Anyway, you can see here, you don't need the investigation for the local involvement, which is seen. But the depth and how big and number and whether the nodes are visible, not visible, they seem suspicious, they don't seem suspicious, you need to evaluate. So the first investigation here is sonomammogram.
So Dr. Richa, if I can ask you to just go back 2 slides to that image.
The image of the patient you want to see?
Yeah.
Right.
So,
Yes.
sorry. Right. So here our concern is going to be that because there is that little excoriated sort of lesion there, getting a mammogram done immediately may not be as simple, right? Vandana, madam, what is your take on doing a mammogram when there is an open lesion like that?
Yeah, see, this lesion seems to be a dried up lesion anyway. Okay, so these days the machines what we have are not as they do not require that much of a pressure that this lesion can burst open. Okay, so what we do is put a gauze piece and try to take in case there is no other option. But if it is a bigger lesion, still, when you have seen the breast and you have figured out that it's more inflammatory, then only the sonogram will be helpful in that particular case. Again, if you need to do to see the multicentricity, you will need to go into an MR mammogram, which will be more beneficial because it is not, you don't need to compress the breast, and the patient will not have that much of discomfort as she will have if this kind of a cancer malignancy is there. If you are suspecting there will be exudate or pus coming, discharge coming, blood coming during the compression. So this particular patient, we can probably go ahead because I feel it's not that bad, but there are worse cases.
So because it looks like it's healing, that's
Yeah,
something that
that's
we
what
can
I
do.
feel. It's a little dried up lesion. So probably the mammogram. Okay, so now you're putting up the mammogram, so you can see a spiculated mass in the central sector. There is skin retraction. I'm not sure about the microcalcification, but large mass with spiculations, and grossly I'm not able to see any other lesion, so it looks like a single lesion. There are few nodes, and the left breast shows some macrocalcifications and some small nodules, maybe a small FCC, but the right breast is BI-RADS 4, in fact 4C.
Okay. So this was BI-RADS category 4C. Now what next? Once you get a suspicious mass, we do need a biopsy. So Dr. Neha, what do you prefer? A palpation guided biopsy? So because as it is a very clear-cut case, or you still need an image guided biopsy? You still want to go for an image guided biopsy in cases like this?
In this particular case, ma'am, I think palpable mass lesion is there, then we can go for a palpable guided biopsy. But however, many advantages are there regarding the sono guided biopsies and mammogram guided biopsies, or whatever is the option given. Because if necrosis is there, then most of the times it comes in the core biopsy and it hampers the diagnosis. So it is important to look over the infiltrating margins or the spiculated margins to go for the biopsy.
And there are other images.
Can I make a comment?
Yeah, please.
Can I make a comment regarding the biopsy, whether to go for palpation guided or sonography guided?
Yes, please, Dr. Tanay.
Yeah, so for this bigger mass with skin involvement, I would rather be more comfortable, doing a palpation guided biopsy. The very simple reason is, if the tissue is necrotic and you are hitting the necrotic portion of the tissue, so as soon as the core comes out, you will be able to make it whether you have taken a core from the representative area or not. If you have a good white cylinder which sinks at the bottom of your formalin chamber, then it is definitely a perfectly taken biopsy. And if you take 3 to 4 such good cores which are uniformly white or containing tumor tissue, then I think it should be sufficient enough. There are certain advantages of doing ultrasound guided biopsy, but for bigger masses, like say for example more than 2.5-3 centimeter in size, palpation guided biopsy is still, one can consider that, and we can very well make out clinically whether you have taken representative course or not.
But Dr. Tanay, can I comment something?
Yes, madam, please.
Dr. Tanay, but how many times you can go for a biopsy? You have to do only 1 or 2 passes only. So if it is necrotic, it is you will just make it out on after taking the biopsy. So you will not go again and again to take the biopsies. So
yeah, that is what I'm telling you, that
biopsy to get an adequate tissue.
So I'm going to agree with Neha here. As far as possible, one would advise or recommend a sono-guided biopsy, especially the larger the lesion, the more the necrosis that's possible in the center. And that's probably going to be more difficult for her. But let's be honest, if you're looking at constraints in terms of resource and cost, etc., often in palpable tumors, we're going to choose to do a biopsy directly. The non-palpable ones or the impalpable ones, we will advise USG guided.
Yes.
But if we could, I would think that all of us would want all our tumors to probably try and have a USG guided biopsy, because then that's more representative and it makes Neha's life simpler as well as the patient's.
Yes, see, in our center also, we try to do the same thing, and I totally agree to all of you that the image-guided biopsies have the advantage, since you do not want to repeat a biopsy and you would not want the pathologist coming back and telling you necrotic components. So we prefer, and our physicians and oncologists prefer image-guided, because larger the mass, larger is the central necrosis, and to get it from an area which is likely to be more viable and more this thing, where you can get your IHC samples to be adequate. So it's always better that we do it with some guidance.
No, I completely agree with advantages of image-guided biopsy. The only reason I was saying that Neeta madam must have encountered like 15, 20 new cases in Tata every day. So subjecting every one of them for image-guided biopsy is practically impossible.
So I'm going to be honest, it's a resource limitation where you want to do it, but when it's a resource limitation, then you use your resources more.
So if you have resources, you should go for an image-guided biopsy. Otherwise, palpation guidance will also have a good yield in these cases.
And one more thing, drawback is there, what we face on daily basis. If necrosis is more, then the stroma is not there and the cells are just lying down. So we are not able to comment whether it is an invasive necrosis or invasive cancer or the part of any ductal carcinoma in situ. That is also a common problem which is faced when we see the slides. So that is also a drawback which I'm counting.
So all of you agree for a cold needle biopsy, or FNAC still has some role?
Absolutely none.
Core needle biopsy only.
Ma'am, I would comment over it. If an urgent requirement is there, then FNACs can also be done, because it is not necessary that the patient will wait for 2 to 3 days, and you can go for FNAC also, and if it is clear-cut, then you can work up. And if it is reported by an experienced pathologist, then of course.
About experience, it's the way we've changed our treatments. We'd want IHC before we do anything else. So we'd want the core and the IHC done. So our preference would be to choose a core biopsy.
Okay.
Because nowadays the indications for NACT, they have expanded so much that any TNBC more than 1 centimeter, they are saying that you go ahead and give NACT. So I would definitely rather, explain to the patient that the benefits of core biopsy and make her wait for a couple of days. That is for her own good.
So multiple studies and meta-analysis, they have proven that core needle biopsy should be done in cases of to diagnose a breast cancer. So for this patient, we did a core needle biopsy. It was an invasive ductal carcinoma. And then an IHC was done. So ER was negative, score 0, PR negative, score 0. HER2 was positive, score 3+. Okay, so Neha ma'am, would you like to comment on how you do the Aldred scoring and for the ER, PR, or low ER, low HER2?
Ma'am, actually, we just look on the strength of the intensity of the color, dark chromogen, which is being visible on the tumor cells, on the invasive tumor cells, we comment over it, and the number of tumor cells. On the basis of these number, as well as on the intensity, we calculate the Aldred score. It is being divided into proportion score is 5 and intensity in 3 parts. And that's how we give it the scoring system. 0 and 1 are considered negative in ER/PR, and then further it is being done. Now, when we do the Aldred scoring, we have to look for the majority of the cells which is giving the color. If it is more than 80% are giving 3+, then we'll count it as 5 plus 3, that is 8/8. So this is how we do the Aldred scoring in them. In DCIS, however, we perform it, but it is not recommended to do it. I think in this can be more explained by a clinician whether they want it or not. If only DCIs is there in the specimen, then only then they ask for the ERPR scoring over it. And in HER2/neu, it is being you have asked for the ALRED scoring only. So this is how we do it. And it is an easy method to look for it. There is no subjective, very less subjective variations are there.
So now
So
we have
Hemant
live.
Malhotra from Jaipur. Can I ask a quick question to the panel?
Yes, sir. Please.
So, just very quickly comment on whether an FNAC from the lymph nodes needs to be done or not as a part of the workup. Thanks.
So because our patient was an N0, go for it. Otherwise, I think yes. We'll cover that in coming slides. Okay. So coming back to our case, what are the chances of having systemic metastasis in a patient of LABC, and what is the preferred staging workup? Is it a combination of CT and bone scan, or you go for PET-CT scan in all the cases?
Okay, so I think this answer for the staging workup honestly is again going to be resource related.
Yes.
Found that most of us now use a PET scan because it's a single stage investigation. I'll be honest, there are still some surprises that come up on a PET that can create more problems because you suddenly have new things that come up. You need a biopsy, you don't get clarity on it always. A good CT chest abdo and a bone scan are often also very, very good options for patients. So I think if you have either or available, cost honestly works out the same. So it's about what is available to you, but it's going to be some staging for the lung, liver, and bones and pelvis.
So we all agree that LABC patients, they are at significant risk of metastatic disease. It's 20 to 30%, and they should undergo pre-treatment staging tests. And a recent trial by Days et al., which was the first large randomized clinical trial, PET-ABC, which reported that FDG PET-CT detected more distant mets than conventional staging. And we need to do an image-guided biopsy of the metastatic lesion is not required if imaging findings are fairly suggestive of metastasis. But if there is a single finding which is going to change the treatment or the stage, then we need to have a biopsy proof of the metastasis. I think all of us agree with this?
Yes.
Okay.
Yes.
Dr. Priya, ma'am, so what do you do at your center? A combination of CT scans and bone scan or a PET-CT?
So majoritarily, we do a combination of CT chest, plus or minus abdomen and a bone scan. And if when needed, if we feel that it's a very large, like for the case that you have shown, probably I would prefer a PET-CT because it's quite advanced. Otherwise, we tend to go for CT and bone scan combinations along with CT of the abdomen when needed.
Okay. So we do prefer PET-CT, but because of the limited, availability, this patient underwent a contrast CT scan and bone scan. And luckily, the breast lesion was the only lesion. There was no other metastasis. So just summing up the case, she is a 55-year-old postmenopausal lady, a clinically T4B N0 M0 biopsy-proven lesion, and the IHC is ER negative, HER2/neu 3+. So what is the molecular subgroup of this patient? Priya ma'am, like to take this question?
So she's a HER2 enriched.
HER2/neu enriched.
So how do you say clinical N0? Excuse me, how do you say clinical N0? I thought in the imaging, the lady had axillary nodes, and we haven't done the FNAC. So can you call this clinical N0?
So then, yes, Dr. Vanna ma'am.
Yes.
So the nodes in the mammo, but was it significant? Or how do you define significant axillary nodes in a mammo?
So when you're doing the ultrasound, you will see the nodes with the fatty hilum. If there are nodes which have a preserved fatty hilum, then you do not consider them as significant. The more the rounded nodes, the more hypoechoic nodes, those nodes are significant. And again, the size of the nodes has to be little bigger. Not that micrometastasis cannot be there, but since if you are asking image guided, we have the criteria how thick the cortex of the node is. Anything which is when there is a distortion of the cortex and the hilum, those nodes we consider, and we mention that there are significant nodes or there are insignificant nodes, and we normally tell them that this node needs to be biopsied because I'm not sure of that. So generally it's informed by the on the scan itself we can make out, so we keep a criteria of hypoechoic, rounding, and thickened cortex.
Yeah, okay, but for a CT4, it would be very, unusual for the patient not to have nodes. It doesn't make any difference therapy-wise, but I think just thought I'll bring up the point that
Now, sir,
CN0 would be like tough
so
to call
this
patient.
particular patient has in the mammogram so many nodes. You cannot biopsy or FNAC all the nodes. So you had to biopsy or FNAC the node which you felt was significant, and that significance was probably not felt on ultrasound. So that is why I think they did not consider a biopsy or FNAC in that.
No, I think a biopsy of the axillary node definitely is not needed. It's quite messy to do a biopsy of an axillary node, just an FNAC positive or negative. If you really truly want to call it CN0, then you have to do that.
But there were 7-8 nodes in mammogram. In the particular mammogram, there were 7 to 8 nodes. So I think the radiologist would have taken a call after screening that
even
they
clinically
are
it was
looking.
not suspicious, and the radiologist saw that it was not. So
Yeah, they would have felt that probably the nodes are not significant. The hilum is well maintained. So that is why probably FNAC was not
because of the
suggested.
infective lesion, because we had this patient underwent CT scan after a couple of weeks, and in the CT there were no nodes in the axilla.
Okay.
Okay, so coming back to yes, sir.
I think you should carry on. This is just an academic discussion. Please carry on.
Okay. So coming back to our case, she's a postmenopausal lady, T4B and HER2 enriched. So what should be the treatment plan? Dr. Nitesh, can you please come in?
So I think Nitesh is left for an emergency.
Okay.
I'll take this for him.
Yeah.
I don't think we are at a point where there's a question for this case. It's going to be some preoperative systemic therapy. The choice is obviously going to include some targeted therapy. I think the choice of the chemotherapy, there are a couple of options. Dr. Malhotra is here. Maybe he can talk to us about that.
Okay,
Dr. Malhotra?
Yeah, I completely agree that there is absolute ambiguity that this patient should be treated with neoadjuvant upfront chemotherapy. And you have several options of treatment. One of the options which we most commonly use these days is a combination of two HER2 targeted agents with chemotherapy, what we call as the DCF plus P protocol. And you, of course, need to assess the response and toxicity each cycle. And my personal take, I don't believe in the sandwich local treatment protocol. I finish the neoadjuvant treatment upfront and then send the patient to the surgeon. One issue which also needs to be considered, because we have a very high clinical and PAT-CR rate in these patients, marker needs to be put after 1 or 2 cycles in the center of the tumor so that it becomes easy for the surgeon to identify what to remove later on. Thank you.
I'm actually going to ask Dr. Chauhan, when do your surgeons place the marker?
I'll just go back. Okay.
So, yeah.
So coming back to marker, we do need, further investigation before staging preoperative systemic chemo. If the markers are placed, ideally it should be done before the first cycle. But if for some reason we cannot, at least, after the first cycle, not after that. So we need pre-op, axillary assessment, as Dr. Hemant sir told, that is very important. If you have a palpable node, you need to get a US guided FNAC. Now coming to the placement of markers. So where do you place the marker? In the node, in the primary, or both? And where exactly in the primary tumor? Is it in the center of the primary tumor or at the periphery of the tumor? Because once the tumor responds to chemotherapy, that is not a very homogeneous response. So how do you?
So that is probably the reason of putting in the marker after evaluating the response after initial 1 or 2 cycles. So that tells us whether the tumor is shrinking uniformly from all directions, and that is why we can determine the new center of the tumor and place the marker over there after 2 cycles. For this much sized lump, if the lump is too small to begin with and patient is TNBC, and by the virtue of biology, if you are subjecting the patient to NSCT, then we place the marker from the very beginning before starting the chemotherapy. But for this size tumor, we usually wait for a couple of cycles. And we usually put the marker in the center of the tumor. And nodes, we usually still are not following the practice of doing some sort of sentinel lymph node biopsy in a patient who is clinically node positive, turning out to be YCN0 later on.
But now that is recommended as a 2B, category 2B.
Yes. So for N1 tumor or a single node, we can do TED. So for that, we also put the marker. We have done like only few cases of TED by now. So we usually do put the marker in if only a single node is suspicious. So in the center of the node, we do put the marker also.
Dr. Neeta now?
So I'm going to tell you the problem with doing targeted axillary resection is a lot of logistic concerns. So where the West talks about this, they have access to MARI, which is related to an iodine dye, even including MagSeed, etc. For us, it means a clip and then placing a wire to get to that lymph node to the clip. Logistically, it's a nightmare to do. We also see a slightly higher nodal burden in our patients. So most of us have not really reached there. Like Tanay said, we're all fidgeting with it a little now. We're trying to wrap our heads around the fact that we are comfortable with it in terms of for the nodal burden that we see. So clip in the center of the tumor, I'm going to say that for the tumor, if you feel your patient's not going to take chemotherapy with you, you're not sure about, whether she's taking it close to you, she's going somewhere else. We all have a lot of patients who travel, place the clip at the start. If your patient's going to take chemo with you, the best time, like Tanay said, is after a few cycles when you're able to assess how it's responding and understand the new center of the tumor. For the lymph nodes, cannot agree more with Dr. Hemant Malhotra that you have to have really good imaging, especially if you plan to do any conservation later in this axilla. And today, for a node positive patient, we would really recommend targeted axillary dissection. If for some reason you cannot, then you at least need to do a sentinel node where you're picking up more than 3 nodes and preferably try and do a low axillary sampling. So your yield of nodes is high enough.
So I 100% agree with Samay and Neeta, and that's what we are doing at our center. If it's a large tumor, then we place one single clip in the center of the tumor after 2 or 3 cycles of neoadjuvant treatment. If it's a small tumor, then we do it before the neoadjuvant treatment. Over.
So we follow the same at our center too. If it's a large tumor, after 2 cycles is what the surgeon prefers. But if we are a bit skeptical that the patient will get missed placing a marker, then we try to put it upfront, because some marker is better than having no marker at all at the end of all the cycles. So depends upon how the load of the patients is, but ideal to place in the center and after 2 cycles.
Hemant sir, would you like to comment on the systemic therapy if it would have been a TNBC or an HR positive cancer?
So I think there are again several regimes which are very good and very effective. Most of us follow the TMH protocol, like 4 cycles of taxane with platinum, followed by 4 cycles of anthracycline with cyclophosphamide, and then over to the surgeon.
And you want to give all the chemo upfront? No,
yes, 100%. I am absolutely clear in my mind that sandwich local treatment doesn't appeal to me. I finish my full neoadjuvant treatment upfront. Other than HER2 positive, where you have to continue the targeted treatment post-surgery also. I finish all my chemo up front and then send the patient for surgery.
And so do you use pre-op endocrine therapy alone for ER positive low risk patients?
So if it's like early breast cancer, which is hormone receptor positive, then I prefer surgery first, followed by adjuvant hormone therapy. And if it's a large disease, like a locally advanced disease, then chemotherapy, then surgery, even though the responses of chemo in hormone receptor positive are not as good.
So moving on, when and how do you assess the response to pre-operative, and what do you do if it's a progressive disease?
Can I just ask a question to Dr. Hemant on one of the ER positive questions actually? ER positive LABC is a very difficult situation, sir, and I don't know if we use I have a 66-year-old right now who we are debating what to do. She's like a N1, N2 kind of disease. So should we do NAST? She has some cardiovascular disease in the past. We know we can give Paclitaxel carbo, but maybe not anthracycline. And I thought, let me do a Ki-67. It's come down at about 65%. So I'm saying, do we use these parameters of mitosis? People have argued use Oncotype DX upfront to understand disease, to decide on neoadjuvant chemotherapy in hormone positive, HER2 negative disease.
So Nitesh, I understand the confusion, and that's where the art of oncology comes in, and you leave the science of oncology behind. If it's an elderly patient with a whole bunch of comorbidities, high frailty score, then I would have no hesitation in using neoadjuvant hormone therapy. Over.
Sorry, can I ask a follow-up question to that? Nitesh, would you be comfortable asking for an Oncotype DX in a locally advanced cancer?
So it's a very it's an experimental theoretical question. Okay, this is not standard of practice question. But if you're talking about up to N1, then the answer is actually yes. I was a part of a very interesting debate at Barcelona this time. I think Dr. Hemant was also there. And the question on the panel that was raised is for N1 disease, where you're likely to do Oncotype DX later if it's truly N1, and decide on chemotherapy, why not do it first and give chemotherapy upfront? And I think that's a very exciting question. And we should maybe start addressing that in some patients, and then it will be a trial in the future. But am I comfortable in using N1 ERPR positive, a T2 N1, where I may or may not give chemotherapy using it upfront? Actually, so recently I would feel yes, I have. Why not?
So I think from this panel with possibly a lot of impressionable young minds listening, Nitesh would 100% agree with me that we should not give this impression that doing a risk assessment, genetic risk assessment is standard of care. It is experimental, some exciting data, but very experimental as of just
very experimental. Agreed, sir. 100%, 110.
Okay, so then how do you assess the response to pre-op systemic? Do you routinely do imaging before surgery or just a clinical examination?
So I think we're going to, Tanya and I will probably both agree that we're going to use a combination of both. I think one will examine the patient first. If you don't have progressive disease, when you examine her, you're definitely going to ask for additional imaging, because if you can, even in this patient, you probably look at whether you can or cannot conserve this breast. Imaging will help us understand the type of response and how scattered it is or not. So it's never going to be just one of the two.
And what do you do in case it's a progressive disease? I agree there is no standard, treatment. So you can go for a change in systemic therapy, add pre-op radiation therapy, or go for surgery. This is okay. So now coming to surgery.
I think that question is based on biology. You can't make that a one for everyone. You'll choose a different answer in a triple negative who can and can't afford, a different answer in HER2 who can and can't afford, and a certainly different answer in ER positive negative. So
So
I
at
feel
our
to this on
center,
that.
for progressive disease, we commonly add radiation therapy because we are comfortable doing it. Neoadjuvant concurrent chemoradiation, and Dr. Arvind sir is here. So he is our angel who operates it after the CTRT also. So I think we are comfortable doing that in the case of progressive disease. Otherwise, if it is operable, we go ahead and do surgery if the change of systemic therapy is also not reducing the tumor. But if it becomes very inoperable and change of systemic therapy is also not reducing it, then I would say neoadjuvant concurrent chemoradiation is an option to make the patient operable. And now that we have got published data, so I think that can be explored when the patient has got no other choice.
Now, what is the radiation dose? What is the dose schedule you are using for pre-op radiation therapy?
So for pre-operative, we have given conventional fractionation of 46 gray in 23 fractions, 2 gray per fraction, 5 days a week, along with paclitaxel.
Okay.
So after the
Weekly paclitaxel or 3 weekly?
no, 3 weekly,
Three
3 weekly paclitaxel.
I think this option should seriously be considered. I don't know if all of you are aware or not. There is a randomized trial going on at Adyar. Dr. Venkat is leading a trial, upfront randomizing patient to CTRT versus neoadjuvant chemo versus upfront surgery. And this is an ICMR supported study. He presented some preliminary reports at the ICC and some very, stimulating data.
Sir, actually, I am the principal investigator for this, and Dr.
Wonderful.
Venkatraman is the co-principal investigator.
My apologies. I did kind
Eagerly
of
waiting for the
register.
results.
My apologies.
Just
Yeah,
begun,
and
actually.
congratulations for a really great trial, very relevant in our country.
Thank you, sir. It's just begun. Actually, we have to wait for some more time till the results come out. But we have completed recruitment for HER2 positive patients, in which we have done a randomized trial, a phase 2 study of neoadjuvant chemoradiation versus neoadjuvant chemotherapy. And that should be out probably by next year. We'll have more answers to it.
Ma'am, I have a very small question regarding neoadjuvant radiation in patients who progress on neoadjuvant chemo. So how long after completing neoadjuvant RT do you subject these patients for surgery? Because we are a bit skeptical about, operating breast patients post neoadjuvant RT. They do have wound-related complications in a very high percentage. I would say almost 40% of them, they develop one or more wound-related issues.
So I think in the published data that we have published in the Red Journal, the IGRO-BP, we have written the surgical morbidity that we saw in our patients, and it was almost the same, like 13% or so. And the usual timing for the surgery is anywhere between 4 to 6 weeks after the radiation. I think if Dr. Arvind sir is there, he'll be able to tell better because we usually see it as a team.
Okay.
Sir, are you there?
No, yeah, I'm there, but no, I guess pre-op radiation is a big thing in many cancers. Of course, it's standard of care in esophagus, rectal cancers. So we are used to operating those cancers. Breast is, as such, no, we don't really have much of the issues. And I must say that it's a very exciting proposition. The preoperative, a lot of buzz, a lot of trials are going on the world over. Of course, the institute has started it off many decades earlier, and of course, Priya is carrying the legacy forward. And I think in the years to come, I think
it's not possible without Arvind sir's support because he's such a supportive surgeon, and he's the part of all my CTRT studies. So he's the surgeon who is principally involved along with the medical oncologist. I think it's all multidisciplinary team approach which we are able to do this. And we are really, excited about doing all this so that we can show our data to the other centers and, probably practice it for patients who are not responding much to neoadjuvant chemotherapy.
Definitely.
Yeah, over to you, Richa.
Yeah. So because of shortness of time, I'll just rush through 3 questions. So for the surgeons, can you do BCS in all the case? And what is we have already discussed about the site of marker placement. So what is the extent of resection? Is it pre-chemo or post? And how much do you resect if it is a complete clinical response? And when do you consider oncoplastic procedure? So 3 questions.
Tanay, I'll answer first if you're okay with that, and then you can.
Yes, sure.
So, can BCS be done in all? I'm going to say for T1, T2, T3s who get neoadjuvant, we're very happy to go ahead. For a T4 patient, Please select your patients correctly. Make sure it's a good MDT which decides it. It's not a single answer for all those patients. The extent of resection is going to be the post-chemotherapy bed, because that's the idea of giving neoadjuvant, is to downsize and make a smaller resection. And as for oncoplasty, I think that's always going to be patient breast size versus tumor ratio, also donor site availability, etc. And our options will be based on that. Fortunately or unfortunately, there's a lot of understanding now about post-chemo BCS in both the clinicians as well as the patients. So we're seeing increasing numbers with that. The only thing I will say before I hand over to Tanay is, for any surgeon here listening in on this, always place clips on the base bed so your radiation oncologist can give an appropriate boost. Please understand that that responsibility lies with us to be able to mark the bed correctly for them. Tanay, your take on this?
So I guess there's only one question left. When we will not consider doing BCS. So as you told that for all T4 tumors, we need to have an MDT discussion, especially not for T4D at all. Inflammatory breast carcinoma is an absolute contraindication. Again, when it comes to the question of multifocality or multicentricity, we do BCS in multifocal cases nowadays. But for multicentricity, we usually avoid doing BCS. We do not put two incisions and take two tumors out separately till now. And for BRCA positive cases, we usually do not promote doing MRM and prophylactic contralateral mastectomies. We give them the option with watchful observation for BCS.
So now a quick take on reconstruction. Suppose the patient underwent a mastectomy. So when do you do a reconstruction? Before radiation, after radiation?
If it is autologous tissue-based reconstruction, we usually do it at the very same time. And if it is an implant-based reconstruction, looking to the challenges right now we are having in India about getting the proper scaffolding material for implant like ADM, I would rather usually prefer to do an implant-based reconstruction somewhere 6 to 8 months down the line post-radiation. But for autologous, immediate reconstruction.
Okay. And how do you manage axilla in a clinically N0 LABC patient post NSCT? It's still, it was CN0, it is YN0.
So CN0, we assume that it was clinically and radiologically N0. So we can very well do a sentinel lymph node biopsy if all the skin changes by now after chemotherapy have been subsided. So I would be comfortable in performing sentinel lymph node biopsy if the skin changes have subsided.
I'm just going to say a little bit word of caution, because this patient was T4 to start with and not T1 to T3. Is when we do a sentinel node biopsy, we've always pushed saying at least 3 nodes in a post-chemo setting. We want to get adequate yield. I would push a little bit more saying in a post-chemo setting, I'd probably be a little happier with the low axillary sampling, just because I want slightly better yield since she was T4 to start with, just to be sure.
So this patient underwent a mastectomy with the axillary lymph node dissection. It was a YPT0N0. So I request our Dr. Neha, how do you define PCR? Do you follow the FDA AGCC or the RCB score? Are you routinely using the RCB score?
No, ma'am, not routinely. Actually, it is not, it is optional. If a clinician asks, then we do it. Otherwise not. We just follow the protocol of doing, whether it is a complete response, partial response, or poor response. And we complete map the tumor bed and see the sections and look for the tumor, whether what is the response, what is the cellularity, whether it is invasive, whether it is DCIS present or not. And similarly, what are the effects? What are the cytological effects? What is the effect on the background, on the stroma? What is being seen? Then we comment over it. And also in the lymph nodes also, we have to comment it. That is the guideline. So we do it like this. So complete pathological response we give whenever the invasive carcinoma is not there. No tumor cells are there. And if DCIS is there, we just mention it that what grading of DCIs is present or not. And in lymph nodes or LVI, if it is there, tumor is there, then we do not give it as a pathological complete response.
So coming over to Priya ma'am, so what is your take on radiation in LABC after pre-operative systemic therapy and surgery? Do you give, is it indicated in all the cases? What are the target volume, the boost volume, the fractionation?
So, in LABC case, definitely after neoadjuvant chemotherapy, irrespective of the pathological staging, definitely radiation is needed. If it is BCS and we have not proven the node, but clinically there were a lot of nodes on mammograms. I would definitely prefer to treat the whole breast and the supraclavicular nodal regions along with the internal membranes because it's an upper inner quadrant tumor. And I would like to treat all these nodal areas. And the fractionation that we practice commonly in Cancer Institute is conventional. That is 2 gray per fraction for 25 fractions and 50 gray. We can also practice the start B or the fast forward, whatever is suitable depending upon the institutional practice. Tumor bed boost 10 gray will be given in 5 fractions. That will be the conventional fractionation used.
So there have been studies on the impact of radiotherapy after a complete response of PCR from neoadjuvant systemic therapy, but radiation has to be included because that adds to the locally control and disease-free survival. And any comment on this ongoing NRG oncology trial? A selected subset of patient T1 to T3 N1 with a complete PCR and undergoing mastectomy, can they be avoided adjuvant radiation therapy?
So early results have shown that in some selected patients of clinically N1 who become Y N0, you can avoid and see because 5-year results have shown no difference in the DFS or OS. But again, in breast cancer, we have to wait for 10-year results because that is a long-term result. So currently, the only long-term results that we are having is the EBCTCG, which we follow like a Bible. So I think we have to have a little bit more caution before we say we are not going to irradiate the patient because of the pathological response. So
adjuvant radiation is to be used in all patients undergoing neoadjuvant systemic therapy. And before we de-escalate radiation therapy, we need to wait. Yes, Hemant sir, would you like to comment something?
I wanted to ask a related question, like if we are thinking of omitting one local treatment, can we think of omitting surgery and just making do with chemotherapy and radiotherapy? Due respect and apologies to my surgeon colleagues.
Sir, you're really trying to egg us on, aren't you? So I'm going to say that fortunately we're not there yet. The data from the group from MD Anderson, I believe, which was published in Lancet 2 years ago. 58 patients, very early tumors. They were 2 centimeters to start with. Residual tumor disease was 0.9. 16 cores or 15 cores on a median, of which 15 cores, which are of a 14 gauge gun, is effectively going to be the entire tumor bed, more or less. Told us that, that was an option we could start exploring and consider. But I think for a locally advanced group, our risk of recurrence is so much higher that we will really need very, very stable data to be able to discuss de-escalating either one surgery or radiotherapy locally.
Yeah, really happy to hear that. I'm very, very fond of my surgeons.
Okay, so what is the radiation technique you're using, the preferred? Is it still field-in-field 3D CRT or going for IMRT? So, any difference in technique for right and left-sided breast cancer?
So definitely for left-sided, we have to, it's a standard of care to do deep inspiration breath hold technique and IMRT with image guidance. That is the standard of care. For right-sided, 3D conformal radiation therapy with field-in-field technique is more than enough. As long as our constraints of the lung and heart and of the LAD are met, I think it doesn't matter what technique we use, but definitely for left-sided DIBH with IMRT or otherwise 3D conformal radiotherapy with field-in-field technique.
And ma'am, what are the contouring guidelines you follow, the RTOG or the Danish?
We follow the RTOG guidelines because that is more preferred for our type of patients, that is early and locally advanced. And the other guidelines are more for early stage breast cancers. There's the EASTO and the RADCOMP and the Danish guidelines. So we prefer RTOG.
So we have discussed about radiation. Coming to Hemant sir, any adjuvant therapy?
No, I have a question to my radiation oncology colleagues and my surgeons. If a BCS has been done and, obviously radiation will be done after that, then you have a very, indurated and lumpy kind of breast. And then how do you make out? I mean, I can't for the life of me make out whether this is post-radiation effect or this is the disease coming back. I mean, how frequently can you image? I mean, you go through the charade of palpating, of course, but I find it really difficult to make out between post-radiation induration and early disease local recurrence. So how do you guys do it?
So I
Excuse me,
agree.
I'm really sorry to interrupt, madam. We have only 5 minutes left. So if we can please wind up, because we should not shoot over the time. So maybe
Yeah,
5 minutes extra, but let's just
So,
try to wrap this up.
I
Thank
think
you.
quickly, an MRI of the breast can differentiate to a large extent between disease recurrence and induration. And I agree that it is a problem sometimes when the surgery is very extensive, like post-oncoplasty. When, a large volume of the breast has been displaced, we do face a lot of induration. More so with the hypofractionated also, I feel. That is why we prefer conventional, because the cosmesis and everything and the feel of the breast is more better after a conventional radiation. But otherwise, an MRI can be done to differentiate.
So
So I
coming
would
to
also add to this is many a times after complex oncoplastic surgeries and radiation, we do get a lot of fat necrosis beneath the scar, and it gives a constant feeling of lumpiness. But usually our radiologists are able to tell us that we are dealing with fat necrosis and not an actual recurrence on sonography only, and MRI we keep it reserved for equivocal findings on ultrasound.
So
Okay, so
normally ultrasound is helpful because you can pick up fat necrosis, as you have said, but good contrast enhanced mammography will actually rule out if there is any early recurrence.
So we have well-defined, guidelines for adjuvant systemic therapy, and our patient needs to complete 1 year of anti-HER2 therapy. So now, last but not the least, Dr. Mansi has been waiting. So coming to genetic counseling. So how important is it? What are the indications? When should we refer our patient for genetic testing? And what should be the role? Dr. Mansi?
Yes. Hi, Dr. Richa. I'm here. So, like indications about genetic counseling or testing. So, any patient, any breast cancer patient less than 50 years of age, with or without family history, they should be referred for genetic counseling first. So that is usually called as pre-test genetic counseling. So like patient understands the pros and cons, the future aspects, the future implications of genetic testing, and then they can go for it. Or actually, if you see that, okay, patient don't want to go for genetic counseling and you want to directly recommend a genetic test, that also can be done. But any patient less than 50 years of age with breast cancer, they should be so genetic testing should be offered to them, be it with the genetic counseling or without genetic counseling.
So what are the genes you recommend? Is it only the BRCA1, BRCA2, or now you recommend some more?
More, actually, you are showing on the slide. So many genes are there, like BRCA1, BRCA2, TP53. We usually miss TP53, but that is also a very important. So because we find somatic mutations of TP53. So clinicians are aware, okay, we find TP53 mutations in the tissues. But in germline also, TP53 is the second most important gene after BRCA. Then PALB2 is there. Yes, PTEN is there. CDH1, ATM. So CDH1, ATM is sometimes checked too. These genes are responsible for late onset breast cancer. But for early onset breast cancers, these BRCA and TP53, the PALB2, PTEN, these are very important. There are certain indications of each one of these. Like for when we suspect BRCA, we usually suspect in triple negative breast cancer, mostly BRCA1. When it is triple positive breast cancer, we can suspect TP53 or PTEN. Obviously, we have to take the family history. So when patients come for genetic counseling, clinical history and family history. So together, and then we calculate the risk, then we decide which genetic testing should be offered to them, only BRCA or a panel.
Okay. And suppose if the patient gets, a pathogenic variant or a likely pathogenic variant, then what next?
Yeah. So are we talking about BRCA for now?
Yeah. So let's
Pathogenic.
talk about BRCA. It's the most common. Yes.
Yes.
Okay.
So once a genetic test report has come and it is so there is a pathogenic or a likely pathogenic variant in BRCA1 or BRCA2, recommendations differ. We usually think that okay, it is same, but usually BRCA2 causes a little late onset breast cancer. BRCA1 cancers are usually early onset and more severe. So the management differs, as you are showing on the slide already. So yes, these recommendations are given, but sometimes suppose a 45-year-old patient is coming and triple negative breast cancer. We have done the genetic test report. She comes positive for BRCA1. Then we will suggest, so it depends when the patient is referred to us, right? Referred to a genetic counselor.
So
Is
when
it
do you
before
ideally-
surgery?
Okay, so when do you ideally want us to refer the patient to you?
So there is no ideal scenario, I guess, because so previously, like we team with Dr. Tanay and other doctors, so we were also discussing that when should we refer. So sometimes before surgery, but I would say once they are done with their primary workup, if this decision needs to be taken that okay, whether mastectomy needs to be done or BCS needs to be done, then before that. But if that decision doesn't change whatever the genetic test result is, then after all of that, because patient is already they already needs to do a lot. So once the surgery is over, the chemo decisions are over, then during that process, once they come for follow-up, they can be referred at that time. But yes, if surgery decisions needs to be taken, and if we have time, because genetic test reports take 20 to 25 days usually to come. So we should have that time in hand. Then before surgery. Otherwise, after surgery, when they come for follow-up. And then because you have asked that what next. So an important point is that okay, for the aim of genetic counseling is the risk of recurrence, whether they are going to get what are the chances of getting breast cancer in future, and is there any chance of other cancer in a patient. So for example, in case of BRCA, it is, we always talk about ovarian cancer. That what is the risk of ovarian cancer? Do they need to think about RRSO or not? So, and then comes family members. Once we tell them about the risk, so risk in the patient, and then we come to the family members. Usually when females like breast cancer patients come, they are always worried about their kids, their daughters. So that part also is very important in genetic counseling.
So thank you,
One
Dr.
quick
Mansi.
comment, Richa, if you will permit me.
Yes.
Like we very recently worked on a document of HBOCs, particularly reference to our country. And the document is ready and it's gone for publication to the Indian Journal of Medical and Pediatric Oncology. And it should be there in the next issue. So I very strongly recommend that you look at it. And there are some India-specific, consensus statements from a group of experts. So, for example, Mansi is saying that all patients under 50 should be tested. We put the age cutoff as 40 because I think 50 is more of a Western recommendation. So, I really truly suggest some of you panel members are authors on that document. So, please look at that document whenever it comes. So, it's just about to be published maybe in a week or 2 weeks. Thank you.
Okay, thank you, sir. So, sir, this age of less than 50, when we talk about it, so it's as per NCCN guidelines also, but according to the American College of Medical Genetics guidelines also. You are right that yes, mostly the West data is involved. But many times
Thank
we
you.
see.
Richa, can you thank you. I think we are really short of time. Richa, can you just quickly
Thank you, Dr.
through the
Mansi.
summary?
So with such eminent, panelists, I would have loved to continue the discussion. But now I think just with a message of, as it is a breast cancer awareness month, hope we all stay in pink of health. And I will hand over it to Dr. Savita.
Thank you, Dr. Richa. Wonderful panel. Thank you to all the panelists. All of you have done an excellent job. So now I'll hand over to Dr. Arvind to do the legalities, the formal announcement for the next webinar, and also to give the vote of thanks.
Right, yeah. Thank you, Sabita. And I hate to stop you all. The discussion was really free flowing and so many diverse perspectives. I think this is the first ISO virtual webinar series that we wish to present, and we discussed this briefly in our last EC meeting that we had in the sidelines of the MVR ISO Con in Calicut. Sabita proposed it, and every member of the EC gladly agreed, and I'm so happy to note that in this first edition of this webinar we have close to 300 attendees, and I would thank the attendees for their eagerness, enthusiasm, participation, and trust in us. I would also like to thank the course directors, of course, Sabita. I think she's been a really live wire, keeps pushing us quite a lot, as well as Sumant and Sameer as well. Also to the ISO president, Dr. Toprani, also to the senior members, Dr. Bilimaga has joined us, Dr. Hemant Malhotra. I think great to understand your perspectives, and looking forward for your document on the HbA1c data as well. I would like to thank Richa. I think silently you've just taken us through a relatively day-to-day clinical problem of LABC that we see on a daily basis. But then I would like to thank you for your moderation and also the diverse perspectives given by all our expert panelists, Neeta, Tanay, Priya, Vandana, Neha, Nitesh, Mansi, and of course Hemant sir as well, chipping in with his sort of interesting perspectives. Must say that ISO is truly a multidisciplinary body. We do have members from all the important clinical as well as the allied and basic scientists as well. So I would urge people who are not members of the ISO. I think I'm sure that a lot of you are members, because we are, in terms of numbers, we are a really big and vibrant body. But in case some of the youngsters, I would urge them who are listening to us, who are not yet members, please visit our website and become members. I also like to thank Mice Ideas for the coordination and our background work that we do. And as was said, I think we plan to continue this virtual MDT series every fourth Wednesday. And the next upcoming webinar would be on lung cancers. Lung Cancer Month is on November. And again, it will be on November 27th of the fourth Wednesday. And see you all at 7:30, and hope to have another great show hosted by the ISO. Thank you, each one of you all, and good night from all of us. Thank you once again.
Thank you.
Thank you so much.
Thank you, Richa madam. Thank you, everyone.
Thank you.
Thank you and good night.
Thank you. Good night.
Thank you.
Thanks everybody.
Bye-bye.
Good night. Really enjoyed. Thank you.